Okay, thanks for waiting there. Over to you, Paul.
Peter, thank you so much. So I'm really delighted to be here this afternoon to introduce a friend and colleague, Professor Roisin Haslett, who is a recipient of one of the University of Manchester's honorary MAHSC professorships fairly recently in the Division of Medical Education in the School of Medical Sciences in our faculty at the University of Manchester. And I'm really pleased to be here because Roisin and myself go back surprisingly quite a long way. I mean, we were in the same graduating year at medical school, and I'm going to say the year, Roisin, 1989, which seems a desperately a long time ago. But our paths kind of diverted for some years. But then I was very fortunate to end up being appointed as an honorary consultant at what was then Hope Hospital, or now Salford Royal Hospital in the Northern Care Alliance, for me as a consultant in ICU, and Roisin a couple of years before as a consultant in anaesthesia and intensive care medicine. So we've got to work together again for another 20 odd years or more, which is great. And frankly, I witnessed firsthand Roisin's pivotal contributions to what I would call growing kind of safe and inclusive care at Salford for some of the most vulnerable adult patients, in the region. And she really helped steer and made a massive contribution for us to become one of the largest receiving ICUs in the UK, with national significance from Roisin's work in growing diversity in workforce and careers. I mean, Palmaris is quite remarkable in medical education, as well as juggling a full-time NHS commitment and also family life as well. So it's just been amazing to witness. I mean, she developed a real sustained commitment to designing and delivering, effective local, regional, and national postgraduate education programs across a whole raft of clinical specialties. And I'm sure you're going to hear a lot more about that today from Roisin. I mean, she was very active in developing as a director of postgraduate education in Salford back in about 2018 to 2016. And that was, I think you really transformed that role, Roisin, and then went on to regional responsibilities in hospital and community care, lots of leadership roles. And eventually a really fantastic that you were appointed following a national competitive appointments process as the current NHS England Northwest Regional Postgraduate Dean and responsible officer over the last year or so. And this is, an appointment at such a critically important time for the NHS and its future workforce. And Roisin, as I can't think of a better person to be doing this, however challenging that role is. And also your links with the local university ecosystem in developing the future workforce, and particularly with us at the University of Manchester. So Roisin, Professor Roisin Haslett, over to you.
Thank you very much, Paul, for that very kind introduction. Let me just share my screen.
Roisin, I think you're on mute, unfortunately.
Sorry, let's just try again. So am I still screen sharing there?
Yes, we can still see your screen, but we can't see the slides now.
Okay, yeah, so I'll go back to the slides. Is that all working now?
Yep, we can hear you. We can see the slides. Off you go.
Great, thank you. So I wanted to talk today about postgraduate medical education. And what I wanted to do was, PGME is a really broad church. There's lots of different elements of mentoring, coaching, assessing, pastoral, career support and exam support. And I was going to do a review of my career journey, pointing out a few of the highlights, talk a little bit about the teaching opportunities, careers, mentoring and educational research, supervision roles, trust and deanery roles. And then I'd be very happy to take any questions either during the presentation or at the end. So my career journey, well, as Paul said, it's been quite long, and I have caught up with Paul many times over those years. So I was a University of Manchester student from 84 to 89, and then I did house jobs also I did those in Chester. So I've worked across the Northwest for the whole of my career. Then did a little bit of medical SHO jobs. I moved into anaesthesia, and as far back as my elective, in 87, I worked in Canada and worked on an intensive care unit. And intensive care had interested me from that time. I was appointed to an anaesthesia SPR post because at that point, that was the way to do intensive care. But I also started at that point being involved in education, became an ATLS and an ALS instructor. I was a consultant in Salford from 99, and I did anaesthesia for the first sort of 18 years of that, and only intensive care for the last few. I also then, from becoming a consultant, became heavily involved in education. I became the tutor within 18 months of appointment, then went on to be the foundation programme director, the DME, and then took on roles within the region. So I've been an associate, a deputy and a postgraduate dean. I'll talk a little bit more about those roles in a minute. So how did I actually develop? They're the jobs I had, but what did I actually do? So throughout this time, I built up quite a significant portfolio of experience and courses and qualifications to support my education and clinical career. So I did my postgraduate exams, then did a diploma and a master's in medical education. Also did a lot of other courses. Barrett's value training was really interesting. And then did lots of training in inclusive leadership, unconscious bias, NCAS training, anti-racism training, but also a lot of experiential learning. And looking at the things that were pivotal in me being able to hopefully deliver the role well that I'm doing now. I learned a lot from the formal qualifications. I also became a fellow of the Academy of Medical Educators. But I picked up and went on some very interesting CPD as part of education rather than just clinical, and responsible officer training and case investigator training. But actually, the skills that have helped me most, particularly in my dean role, were all non-technical clinical skills that I learned along the way. So educational leadership completely relies on communication, time management, team working, appraisal skills, presentation skills, but also decision making with limited information. Well, that's critical care. Least bad options, that's critical care. Breaking bad news, handling complaints. All of those things were skills that I honed in my clinical practice that have served me very well in my education practice. I'll talk a little bit more about coaching and mentoring later, but managing complexity and breaking bad news are kind of what a dean does most days. So I came involved in teaching, from being a trainee. I support local training sessions and whatever, but I've taught at a local, regional, national and at a multi-professional level. And my entrance into this was actually via the generic instructor courses, and I continued to support ALS, ATLS and CRISP courses for many years. When I was the TSTL at Salford, looking after the trainees within intensive care, I introduced the Regional Advanced Intensive Care Medicine Programme. This was trainee-led and it had a mixture of lectures, journal clubs, etc. And then when I became the Foundation Programme Director, I had to deliver the 2-year teaching programme for the foundation doctors that lasted across F1 and F2. And it had to cover large portions of the curriculum, and it had to cover both clinical and non-clinical skills. And at that early stage of doctors' careers, it's actually a little more difficult to get them sometimes to engage in the non-clinical work. The clinical skill, this clinical teaching, they see as more obviously applicable to their day-to-day work, and engaging them with some of the non-clinical topics was potentially more challenging. This is just a highlight. So one of the highlights of my teaching in medical education was in 2019. I was very lucky to be able to run a course, co-run a course in St Lucia, and it was for the clinical leaders of the island, and they were the lead doctor, lead nurse, lead pharmacist, lead AHP, and it was funded by a Vision 2020 charity. And what we did was we did a lot of leadership development, did the foundation of leadership, and then how you could understand your team and get it to function. Then taught about quality improvement and the science of quality improvement, because through courses that I'd been on at Salford with the QI programs, they were very helpful. And then we helped each of those clinical leaders come up with an action plan for a quality improvement project within their service. And we followed this up for the next several years. And this led to quite a lot of impact in clinical services in a fairly low income health economy. So that was fascinating. And also what was very, very rewarding about that was how the thirst for knowledge of these leaders was so much compared to some of the groups that you could present to in the UK, who are more used to having these sort of courses more at their fingertips. This was something really quite unusual for that group. But in the last few years, I've spent more time really teaching trainers than I have resident doctors. And so I've done, as the DME, I did a lot of trust-based sessions for our educational supervisors and sessions on reflection and educational appraisal. It's very important in the deanery that our training programme directors have a good, up-to-date knowledge and run the TPD inductions. I also now obviously present at the education and leadership conferences within the region, and there's just a few of the topics that we've covered over the last couple of years. So going on to mentoring and coaching. So I was lucky enough to do a mentoring module as part of my master's, and I've always been quite involved in this area. I formally mentored new consultants on the ICU, but informally, quite a lot of doctors have found their way to my door over the years, often told to come by another colleague. And it was often around careers, and it was often around intensive care, and it was intensive care a possible career for that doctor, and a lot of them were women asking, did women really fit in ICM? And in those conversations, work-life balance was a constant feature. So if we look a little bit about gender split in specialties, there are some specialties where men still outnumber women 3 to 1, although that is not what we see in medical school, and it's not what we see in our trainee cohorts, but by the time you get through to consultant posts. And it isn't that there's just certain specialties that women do and certain specialties that men do. If we look there on the left, that's the medical specialties. Well, cardiology is very, very male dominated, but palliative medicine is very female dominated in terms of numbers. And on the opposite side, if we look at surgery, ophthalmology is the most feminized surgical specialty, and trauma and orthopedics the least, but with a huge variation from 6% to 30%. This is quite old, it's from 2004, but I think it still holds true now. If you split medical careers into people-orientated plannable and people-orientated unpredictable, and again, techno-orientated predictable and unpredictable, intensive care would definitely sit in the techno-orientated unpredictable, along with emergency medicine and anaesthesia and surgery. Now, at the time I looked at this in 2018, intensive care medicine, only 21% of people with the FICM were female. We could see up in GP, it's 42%, 44%. These numbers will have changed over the last few years, but still, I think the principles stand. So women, it was clear that women were relatively underrepresented in ICM. Any career, So what factors may have informed it? Is it just preference? Is it exposure, role models, career structure, access to jobs? Is it life circumstances, or is it discrimination? So I set out to answer two questions. Firstly, what were the experience of female doctors when they were choosing or discounting a career in intensive care? And could we modify or intervene in any way that would make this more attractive to women? The methods are as stated there. And what I found was lack of careers advice and the importance of role modelling was a really common experience for all participants. But the study was interesting because some people perceived their gender to have a significant impact on their career opportunities, but other people didn't perceive that at all. Most people found intensive care a supportive environment, and a lot of people raised end-of-life decision-making as having an impact on their decision to reject this career route. Something else I found very interesting, and this was found in other professions in my wider reading, maternal influence was found to be very important on daughters' career choice, particularly if the female went on to have her own children. So what were the conclusions? Well, all doctors believed that rota patterns did influence career choices and increased predictability might benefit. And that's something that may be within the control of the service. Improved timely careers advice could definitely increase recruitment, and doctors value the importance of female role models, both professionally and within their families. So really what we need is good role models, both male and female, and we need to widen the discussions about flexibility of pathways in careers and have clear lines of support for end-of-life decision-making. We need easy access to careers advice from the right people at the right time. And we need those people to be happy to discuss both personal and professional factors, because these are what drive people's decisions. So in terms of other roles within education, started off being a clinical and educational supervisor. And I think in many ways, this is the most vital and meaningful role. It's where you have real connection with your trainees, and it's very varied and interesting. The TSTL role, or the tutor role within an individual department, for me, that was my first leadership role in medical education. And you're responsible for induction, lots of rotas, and lots of individual resident support. And it was great in terms of getting to know your consultants in the department and understanding what they valued in training, what they valued in trainees, and working with lots of individuals. The foundation programme director role, again, was really interesting, and I liked that because I worked with trainers across the whole trust in all different specialties and got to understand much more the pressures of training in craft specialties, the pressures of training in acute specialties, the pressure of training across multiple sites. Working with doctors in their first job in the NHS, or often their first job at all, is interesting, and watching them grow over that 2-year period was very validating. The DME role, you're responsible for the provision of medical education across the whole trust, and you're looking at the educational governance and the educational environment. You're responsible for induction, and you're working with all the different departments, and that was where I was exposed much more to HR and workforce development work. I also looked after the locally employed doctors, and that's an area that I'm continuing to be interested in the role I'm doing now. So just to tell you a little bit about the deanery and how it works, there's 13 schools, and we have 100 programmes. We have 185 approximately TPDs, and we're managing the recruitment, rotations, appraisal, and all the internal processes for individual trainees, and supporting educators to have the skills and knowledge to be able to deliver these roles. So I've done 3 roles within the deanery. One as an associate dean, where I worked with trusts and schools and also worked on the leadership offering. And deputy dean role, where I led on medical workforce, and that was across the region and nationally to look at how we supported under-doctored areas within the region. I also oversaw the COVID recovery budget. And we've also, in the last couple of years, developed a professional support and wellbeing unit, which is supporting individual doctors, particularly concentrating on issues with repeated exam problems, or doctors who are presenting with neurodiverse characteristics and how we can support them to thrive in the workplace. And that led me on to becoming the regional dean last year. And this is a job that has sort of three main areas that you're covering. One is the national roles, where I'm the lead dean for the College of Emergency Medicine and also the College of Psychiatry, which are great, two very different colleges supporting very different professional groups, and very interesting. And I continue to lead on leadership development. I'm also very involved in the EDI and sexual safety committees, because we have a very diverse group, and sexual safety is an area that's under a lot more scrutiny, and rightly so at the moment. You have a large statutory role, so I'm the RO for over 9,000 doctors, and that involves quite a lot of work with the GMC to make sure that the professional standards are upheld. And in my regional role, I support 140 permanent staff. I'm responsible for medical postgraduate education, but also for dental and pharmacy, and for learner support and faculty development. So I just thought, as a final slide, I'd just try and show you a little bit about the size of it. So I'm heading up a team that looks after over 9,000 doctors, and 2,000 of those are foundation trainees. There's about 5,000 educators that's supporting all of this, and they're split into 13 specialty schools, and they're running. So thank you very much, and I will take any questions. I'll just stop sharing my screen.
That was great. Thank you very much, Roisin. Apologies if anyone had a bit of stuttering on the slides there. I think there might have been a slight connection issue with the Health Innovation Manchester Wi-Fi, but hopefully it came through okay on the recording. So just before opening up the floor to questions, Roisin, I just wanted to speak a little bit about the direction that MAHSC is going in a little bit with relation to clinical academic training.
Yes.
So I think that ties in really well with some of the things you were speaking about there about your educator role. Do you think that it's a good direction for us to take, because we're kind of at a bit of a crossroads at the moment with MAHSC, where we're trying now to start with the Research Opportunities Support Office, which is all about delivering non-clinical education for clinical staff. Do you think that's something that's a good direction for us to take at the moment? And I think, is there a way you could tie into that with us?
So I think there's several different parts of that. I think there's leadership development, there's research development. These are all core non-clinical skills that doctors need. And the accessibility, so they feature within leadership, for example, features within every postgraduate curriculum. But the previous offerings and the funding for those offerings are getting tighter and tighter and more difficult. And research, again, everything is, finances are very tight at the moment. So I think working collaboratively across organisations to try and support these agendas must be the better way forward. It's how we keep people engaged. Also, training is people are less keen to travel long distances and move multiply around the country. There's generational differences, and that will have an impact on adding that extra string to your bow of research into your clinical career, adds an extra level of complexity and layer of complexity to your own career planning. So I think we do need to work closely on those to make sure that we do get the researchers that we need in the future.
Absolutely. So I just wonder if it would be helpful for you to have maybe sit down with Mary Marshall and Lucy Dwyer, who are leading on from our women and children's research domain side of things. They've been running a number of MFT focused workshops at the moment, but really about getting early career researchers or nurses who have not really considered research before, about getting that research pathway started. So I think then maybe developing something about leadership would be really helpful as well, because that's the other element you're speaking about there.
Yeah.
Yes, I'll open the floor up to someone else to speak now. That's just my two cents. So, thanks, Roisin. Paul, would you like to come in there?
No, important question, Peter, and I'm glad you had a chance to offer it. Roisin, thanks for your talk. It was really excellent, and learning about the scale of operation is quite amazing. We think in the university sector we have a large scale of operation, but looking at your practice, it's impressive and enormous. I mean, one of the challenges we have with undergraduate, and I'll say healthcare education at the moment, and that not just limited to doctors, but the broader workforce, is student experience in the work, and it is a major challenge for us. And sat in higher education, a bit difficult to fix. I mean, we've got to do this in partnership. I just wondered, from your lengthy experience, where you think we should concentrate in terms of driving improved student experience in the workplace.
I think in the same way as I believe the education supervisor role is the single most important role in education. Forget the whole hierarchy. I think it's your placements. I think it's the face-to-face, day-to-day. It's whether people feel welcome. And I think a lot of that is cultural. I think the sexual safety work is really important. If you look at which healthcare workers are more likely to feel vulnerable in the workplace, whether that's to bullying or other inappropriate behaviours, there is a real hierarchy to it. And the more junior you are, the more likely you are to be exposed to poor behaviours. So I think we need to, and I'm trying to do this with the deans at the moment, and they're all very, very interested in this, is share good information. If we do have troublesome placements, whether they be at an undergraduate or postgraduate level, we need to share the information. We need to have robust ways of challenging poor behaviours, because a tone can be set from the top, and often there'll be behaviours that we as seniors simply don't see because people don't behave like that in front of us.
Yeah.
But more junior colleagues are seeing quite a different side of things.
Yeah, that's really helpful, Roisin. And it just seems, with the pressures in healthcare delivery, health and care delivery at the moment, it seems to be amplified. So that's really helpful advice, and I'm pleased some of those things we're pursuing with our delivery partners. So thank you.
Thank you, Paul.
Thanks very much, Paul. So just before we close at 1 o'clock, we're just approaching our final few minutes here. Did anyone else have any comments or questions for Roisin before we close the meeting?
Yeah, I'll do a quick one if that's okay. I don't think any of in the chat, so I thought I'd take the opportunity. Obviously, Roisin, I see kind of from a personal perspective a focus on lifelong learning. Is that almost kind of like a mindset that you would seek to nurture within kind of the healthcare professionals of tomorrow, that learning is never finished? And is it a mindset thing to kind of always be open to educational opportunities, or how would you kind of characterize it?
I think it's quite difficult to explain why you did the things you did then. I just took opportunities that turned up. So the fact it was a wiggly route was deliberate. There wasn't a grand plan. I didn't set my sights as a new consultant on being a postgraduate dean. I'd have thought that was crazy. But I took a lot of opportunities along the way, and it was very, very interesting to go into different parts of, some of the CPD I've done in education has been absolutely fascinating and completely different to my clinical practice. But you'd go back to clinical practice and the skills are all transferable. And I think the idea that you're just building your own skill set and then opportunity may turn up, and at that point you may be in a better place to take those opportunities. I think earlier on in your career it's all quite bit of a railroad, and there's clearly you do A, then B, then C, then D, and one thing leads to the other. I like it being more open, but you can then just pursue different interests. And I could have equally decided to go to pursue a clinical leadership pathway career-wise, but I just happened to go down the education leadership pathway. But it's all the same skills, and I often have education leaders who are previously clinical directors, and in some regions that's much more common, swapping between the two.
Thanks, Ben. Okay, I think because we're 2 minutes past 1 now, I think, Roisin, unless you had any closing comments?
No, just thank you very much. It's been great to be able to present to you today, and I appreciate it. Thank you.
Brilliant, thank you. So I'll bring the meeting to a close there, and just thanks again, Roisin. That was a really, really interesting talk, and thanks everybody for joining us today.